So if you think about what happens when your metabolism is increased, what happens to your body? You're hot, you're sweaty, okay, you're kind of jittery, you're even nervous a little bit. Okay, remember that word exophthalmos? That's that bulging of the eyes. Okay, you'll see that here as well. Yeah. Anyway, so hyperthyroidism is also called Graves' disease. You guys have to know about Graves' disease as well. Also known as Graves' disease. Okay, or exophthalmic goiter. When I say exophthalmos, I'm referring to the eyeballs, right? Okay, coming out. Goiter is the enlargement of the thyroid gland. That's what it is. Okay, also known as exophthalmic goiter and thyrotoxicosis. Okay, essentially the thyroid gland, it's intoxicated. It's producing too much of its hormone, so it's not regulating metabolic processes adequately. It's overproduction of the thyroid hormones, T3 and T4 primarily. These are responsible for the regulation of metabolism. Exaggeration of metabolic processes, the exact cause is sometimes unknown. So again, what's the patient going to look like? They're going to be very skinny. If you think about metabolism, folks, think of it like you working out. What happens when you work out? You get hot, you sweat, your eyes don't bulge out. But that's what happens here. And your body, you become very thin because your body is breaking down elements and utilizing them real quickly. You have an intolerance to heat. I mean, you can't, if you're working out, okay, you don't want to go to the sauna because you're going to sweat more, right? I mean, you do want to go. You're going to have an intolerance to heat, meaning it's going to feel uncomfortable. So that's what's going on with the patient with hyperthyroidism. Okay, these are a couple of elements, and write these down if you can. They're all in the book, okay? But these elements are in there, and after today, before you guys leave, I'll run downstairs and I'll make you guys a copy of these little sheets that will give you guys a heads up as to what the clinical manifestations are. So we have an intolerance to heat. The patient's always hot because their furnace, think of their body as a furnace. It's heating, it's working consecutively, so the patient's hot. They're going to be sweating, fine straight hair, bulging of the eyes, exophthalmos, you have to know that word. Facial flushing, the patient's going to be red. Okay? Enlarged thyroid. Now, what happens when the patient has an enlarged thyroid? What do you not want to do, or what do you want to do very carefully?
Palpate.
Yeah, palpate it. And the whole reason, folks, is because we don't know why the thyroid gland is excessively producing T3 and T4. So if we manipulate it and we press on it too hard, it might produce more. Okay, so that's how, if we do assess it, we have to be very careful. Tachycardia, because again, the metabolism is increased, right? So your heart rate's increased as well. What happens to your blood pressure? It goes up as well. What happens to your respiration? It goes up as well. What happens to your temperature? It goes up. Now, the temperature is relative, meaning if your baseline is a 97.8, then you're looking at maybe a 98 point something, a full degree higher. Does this mean that you're constantly at 103 point something? No, you don't have an infection. However, your body's hot, okay? And you usually feel it. These patients, when they sleep without blankets. Okay, they don't want to really, they don't want to cuddle, okay? Because they're hot. You'll have breast enlargement as well. Patient's going to lose weight, muscle wasting as well, and they'll have localized edema. Now at this point, folks, these patients are retaining a little bit of fluid, okay? So they'll have a localized edema. They're going to have clubbing of the fingers, tremors, increased, the diarrhea is going to be increasing as well because the metabolism is really quick. They're not digesting properly. So as the food starts going down the GI tract, they're just expelling everything, so they're going to have diarrhea. Menstrual changes as well, amenorrhea for females. Okay, that's important for you guys to know. Menstrual changes for females, amenorrhea. Meaning, what does amenorrhea mean? Cessation, right? Or the lack of a menstrual cycle. May I switch the slide? And if you guys have any questions, ask me, guys. It's okay. We have today, tomorrow to do all this stuff. So we have plenty of time. And I'll try to get some tutoring in. Like I doubt it. Okay, I'm gonna switch the slide. All right. This is essentially what's happening, folks. You see the lady, physical appearance on her neck. Okay. Here's one wing. Here's the other. You see the depression in between, right? That's why I say it looks like the Wu-Tang Clan. It looks like a butterfly. Okay, so this is an excessive secretion of T3 and T4. Here it is through diagnostic imaging, you have an excessive growth. This is the cervical spine. And then right here you have the excessive growth of the hypertrophy of the tissue, of the gland right here. It's just getting really big, so it's producing all that T3 and T4. All right, clinical manifestations include edema of the anterior portion of the neck, exophthalmos. Please know what exophthalmos is. Okay, there's no excuse why you guys shouldn't know that now. Exophthalmos. Inability to concentrate, memory loss. This is really big as well. The patient's body is continuously increasing its metabolic rate, so the patient has a hard time to really focus in on things because everything's quickening. Everything's happening real quick. The patient has dysphagia. Why? That's why they can't swallow because it's so big. Hoarseness as well for the same reason. Increased appetite, because if the body's utilizing more energy, it's going to be requiring more energy as well. Weight loss and nervousness as well. And that's what exophthalmos looks like, by the way. Pretty attractive, right? And that's just like patient. If the patient's body's constantly working, they're not going to be able to sleep adequately, so they're going to have insomnia, tachycardia, hypertension, warm, flushed skin, fine hair, amenorrhea, elevated temperature, diaphoresis, and hand tremor. This is stuff that we discussed already. Any questions on the clinical manifestations of these patients, guys? Okay, does anybody have hyperthyroidism in here? No? Yes?
Can I get some of them? Some things, not all of them?
What was that? You have some of those things?
No, we can't get some of them and not all of them.
Oh, I see what you're saying. Yeah, me too, me too. All right. Now let's talk about medical management, folks. There's only so much we can do to decrease the production of T3 and T4. Primarily, we're just going to remove the thyroid gland. Okay, either partial, a portion of the thyroid gland or the entire thing. So we can also give these two medications right here, profylthiouracil and methimazole. What these medications do is they try to decrease the level. They bind to the T3 and T4 hormones and they try to excrete it through other metabolic processes. However, in my experience, guys, with hyperthyroidism, it's really difficult to control it. Okay? They can do a radioactive iodine, okay, but essentially what's the main one? Surgical procedure. Now I want you guys to know something. It's very common for patients that have either a subtotal or a resection of it or the entire thing. When they have it removed, especially when it's a portion of it, sometimes the parathyroid gland, the one in the back, it's nicked. Okay, and it's affected, so it's going to change its own secretory mechanisms as well. So it might cause hyperparathyroidism as well. Okay, so just keep that in mind. So if I ask you, what are some abnormal consequences that a thyroidectomy may have, and you might actually harm the parathyroid gland as well.
Is this too much that it can regenerate?
It can't. Which part?
The thyroid. If too much tissue taken, the gland will not regenerate.
I was going to say, it can actually regenerate to a certain extent, but you guys remember me talking about stem cells? Mm-hmm. Okay, at one point, essentially the originating cell of that particular tissue. So once too much is actually reduced, it won't be able to repair its removed tissue anymore. Okay, that's why we usually just remove a portion of it. What happens if the patient has a complete removal of the thyroid gland? What's going to happen to them? Then you need something called levothyroxine, a medication to bring up or artificial T3 and T4. Does that make sense? Because they're not going to have any. Pardon me?
For the rest of their life?
For the rest of their lives. Mm-hmm. For the rest of their lives.
If they don't, they blood thin out, right?
Not that their blood thins out.
I mean, thickens.
No, not that either. What ends up happening is that their body can't really regulate the metabolic processes. Okay. Where are you getting the blood from?
Because I know somebody that has it, and they said when they take blood, they got to pump because it's thickening up. If he don't take his medicine, because he don't have a thyroid gland.
Because of the thyroid gland? I'm not too familiar if it plays a big role with hematopoiesis or coagulation. I'll figure it out. Okay. Okay, you guys know when I talk about the radioactive iodine, you guys see that portion right here. Anytime somebody takes any type of iodine, what do you assess for? Hey, where's Edgar?
He didn't come today.
Oh.
You missed him.
I know that. Essentially, folks, when somebody has the radioactive iodine, this is what we're doing. we're giving the patient a pill or medication that has iodine that's radioactive, meaning it emits radiation. That's what it is. Of course, very low in low frequencies. So we have the patient ingest the iodine capsule. As it passes through the system, as it becomes metabolized, the iodine, the radioactive iodine, is uptaken by the body. And if you guys read in the chapter, it says the thyroid gland filters several mLs per day. Okay, so all the radioactive iodine that this uptakes, because remember, what does the thyroid gland need to function? Iodine. So it takes up the iodine that's radioactive, and we essentially measure it. Now, if we have a certain amount of radioactivity that's actually being shown from that particular area, that means that the thyroid gland is actually absorbing it, so that means it's working well. If it's got decreased amounts of radiation radiation activity, that means it's not being it's not functioning well. Does that make sense? So this is like a diagnostic test almost to see what's happening. And again, what complications are going to occur with a thyroidectomy? Yeah, the parathyroid gland may be affected as well. Alright, so post-operative procedure, folks. Anytime you have any surgical procedure of the throat, okay, you want to rest the voice. Okay, you want to, and you do voice checks as well. You want to also avoid coughing and clearing your throat. Okay, roughly about a week. Avoid hyperextension of the neck. This is really important. A tracheotomy tray at bedside, airway of utmost importance. So anytime the patient has this procedure done, what do you want to have at the bedside? Tracheotomy. What else do you want to have? Someone said it. Suction. Which one's more important, tracheotomy or suction?
Suction.
Tracheotomy, because this one actually maintains the airway open. So suctioning is important. Don't get me wrong. It doesn't mean in the real world you're only going to have one. However, that's why we talk about and we emphasize a tracheotomy tray, because the tracheotomy tray has an artificial airway. So if something happens and the airway is affected and it collapses, we do an emergency tracheotomy, and now the patient has an open airway. Does that make sense? So that's why it's this one right here. Assess for signs and symptoms of internal and external bleeding. Okay. Assess for tetany. Let's look at tetany real quick. Okay, because of hypocalcemia. You folks know what tetany is? Pardon me? Spasming, yeah, spasming of what? Of the muscles, that's right. So that's what tetany is for. Remember I said if we actually nick a parathyroid gland, what's the parathyroid gland responsible for? Elevating calcium levels. If you remove or you cut a parathyroid gland, it loses its ability. So what happens to the calcium levels? It goes down. Anytime you have hypocalcemia, you're going to experience tetany. The patient may experience tetany. What's the average calcium levels? 8 point something to 10.4, I think it is.
9.0 to 10.5.
Close. Okay, what is it, 9.0
to 10.5.
So some books will say 9.0, folks, but essentially it's between 8 and 10. So what's hypocalcemia? What's the level that we're going to be expecting for hypocalcemia? Yeah, below an 8. Yeah, below 8.5. Now, if somebody has hypocalcemia, folks, we're going to discuss in a little bit the role of calcium in the body. And let me just try to explain this real quick. Calcium plays a role very similar to potassium. Okay, it deals with the nerve conduction. So when we talk about neurotransmitters or the different neurons sending messages to my arm to do this or to do this, whatever I'm doing. You guys see what I did? I just flipped I just showed the bird. You guys didn't say anything. You saw it? Anytime your body does something, guys, calcium plays a role in that. So if you have decreased amount of calcium in your body, you're going to have an inability to think logically, to move about adequately as well. The same thing with muscle conduction. As the nerves tell your muscles to move or to flex or anything like that, it needs an adequate amount of calcium for that muscle contractility, for the muscle to actually move. So if you have hypocalcemia, it's not going to be able to move adequately and it's going to start spazzing out. That's what your tetany is. Now there's 2 tests that we can assess for that. It's called Schwarzdex and Trousseur's. Think of Schwarzdex with a C for your cheek. So essentially, a patient may have hypocalcemia. We get a patient and we tap their cheek. What happens if we tap their cheek? It'll start contracting like this. That's Schwarzdex sign. That's indication of hypocalcemia. You guys have to know that. Think of Schwarzdex, C for cheek. Okay, the other one, I don't even know how to pronounce that. Was Trousseur's. Okay? That one is, we use a blood pressure cuff, we apply it on the patient's arm, we inflate it, and if the patient's positive for hypocalcemia, they're going to do this. Okay? They're going to do this. The arm is going to start doing this. Okay, so that's Schwarzdex and Trausser's sign. You guys have to know those two. Schwarzdex and Trausser's are these tests that we perform to check for hypocalcemia. Does that make sense? Okay. Now, why will the patient develop hypocalcemia if they had a thyroidectomy? What happened?
Because it didn't have it there too.
You make the parathyroid.
What?
Doesn't have it there regularly.
Okay. What else? It affects the parathyroid gland. You guys have to know that, folks. When it comes to a thyroidectomy, because remember, the thyroid can be the complete removal or partial removal, but a lot of times we cut the parathyroid gland that's responsible for raising the blood, for elevating the blood sugar, or the blood levels of calcium. So if you cut it, it won't be able to raise them anymore. They're going to drop, and you develop hypocalcemia. Schwarzdex and Trausser's. Okay. Set for thyroid crisis, essentially when the hormone becomes very unstabilized for T3 and T4. Any questions on that? Well, mind you, I have slides and all. I just wanted to say it first, and I'm going to explain it in further detail right now. So that's Schwarzdex, the one in A. Okay?
That just makes it twitch.
Tap on the cheek, and it does this. Okay? The patient does this. What does this represent again? Tetany, hypocalcemia. And this is what happens with the hand when you place what? The blood pressure cup. You put a blood pressure cup on, you don't just leave it on there and just wait to see what happens. You pump it up. You got to pump it up. You have to inflate it. Okay? Essentially, folks, what you're doing is you're trying to overstimulate the muscles. And these are two very classic tests that we perform, because we found out that if you put a blood pressure cuff on somebody that has low calcium levels, they start spazzing out. Okay, same thing with the face. We have the facial nerves in our face right here. So if you tap them, remember, you're stimulating the neurons to stimulate the muscle on your facial muscles, right? So if you have hypocalcemia, it's not regulating it well, so it's kind of like spazzing out. So essentially, that's why the patient starts spazzing with their face.
Eye twitches.
Yeah, but the eye twitching, yeah, that's not related to that. But yeah, that's a perfect example. You guys ever had that? The eyelid starts twitching? I've been lecturing up here with you guys, and my eyes twitching for like a long time, and I hope you guys can see it. It is a weird feeling. All right, so we were talking about hyperthyroidism. Let's talk about the opposite now. Okay, hypothyroidism. You have insufficient secretions of thyroid hormone, not enough. Okay, so what's that medication, Miss Susan? Levothyroxine. Level, because levitate, you're elevating, and it's bringing up your thyroid, your T3 and T4 levels. It's the slowing of all metabolic processes. It's the failure of the thyroid or insufficient secretion of thyroid-stimulating hormone from the pituitary gland. It could be either or, because remember, the FSH is a tropic hormone that affects the thyroid gland to secrete its hormone. So it could be either the pituitary gland is not stimulating enough thyroid-stimulating hormone, or it could be that it's just not producing itself enough. Okay, so before we even talk about the clinical manifestations, I show you guys, what does this patient look like? Heavy. Look heavy. What else? They have if the hyperthyroidism had intolerance to heat, what does this have an intolerance to?
Cold.
Cold. Okay, so they're cold all the time. Oh, I need a blanket. Okay. If the other one's jittery all the time and can't sleep, what happens to this patient? Okay, their metabolism slows down, so they're lethargic. They're slow. Does that make sense? Okay. So for hypothyroidism, intolerance to cold, receding hairline, facial and eyelid edema, not dependent edema, dull blank expression, meaning they just have pretty much a flat affect. You folks know what an affect is, right? AFFECT? You guys know what that is? No. All right. Write that down, please. An affect is describing what somebody looks like their mood. Okay, so if you are assessing a patient, right? And you ask them how you doing, and you do your neurostatus, and you do the patient is alert to person, place, time, okay, an event. And then it's gonna have a section that says affect. Okay, what's their affect like? Well, if it's flat, they're like this. Okay, that's considered a flat affect. These patients have a very a flat affect. They're kind of just staring off into space. That's what ends up happening with them when they're just sitting down, of course. Extreme fatigue, thick tongue, slow speech, anorexia. What does anorexia mean?
Not eating.
That they're not hungry, that they're not eating. That's what that means. Brittle nails and hair, because all the bodily processes that maintain the consistency of the nails is slowed down. Menstrual disturbances as well. Let's talk about some late clinical manifestations. Subnormal temperatures, bradycardia, weight gain, decreased level of consciousness, thickened skin, cardiac complications as well.
So
Yes.
if they're not eating, why they gain weight?
Because their metabolic processes are slow. So like let's say you ate, at some point you ate something, right? In your body, the way that it burns off the fat, like when you're working out, it's slowed down. It's not happening. So all the elements that are in your body that are supposed to be utilized, they're not being utilized and they're just being stored. So that's why you end up gaining weight. Does that make sense? You don't look happy about it. You're like, The patient eats eventually. The patient's eating.
No,
They're
I
just
know they eat.
they're just not hungry. Anorexia means they're not eating a lot, but their bodily processes are slowed
I
down.
thought they ate a lot and then the metabolism was slow. So that's what
Oh.
I know they weren't hungry.
Like with
Okay.
people, if they just eat one large meal a day,
That's
they
it.
will gain more weight than a person that eats 5 small meals a day.
That makes sense as well. Simply because of the metabolism, the furnace. Okay, if you think about us putting, I was gonna say leña. Leña is wood in a chimney. Okay, but if the metabolic meaning the way that it actually burns is so slow, it's just gonna take forever to actually burn off. That's kind of the same thing right here. Patient will have hair loss, apathy. You folks know what apathy is? An indifference, not caring. The worst thing in this world is apathy. People just don't care sometimes. That's apathy. You know what apathy is? Yes?
Oh, I said I'm happy.
You're apathetic?
Me too.
Really? That's horrible. I had a friend in high school that he had a clothing line, and he would apathy. That was his clothing line. He didn't sell anything, but it was cool design. Anyway, lethargy. You folks know what lethargy is, right?
Tired.
Being lethargic, tired all the time. Dry skin, muscle aches and weakness, and constipation. Notice how the other one was diarrhea? Constipation. Okay? And again, hypothermia, intolerance to cold, weight gain, depression, impaired memory, slow thought process, lethargy, anorexia, constipation.
So anorexia, though, something, you have to be under a certain weight to be considered anorexia, so.
The term anorexia is just the that you're not eating, that you're not hungry. That's what anorexia means.
It's not that your body, like you're not capable of eating, you're making a choice, that's what anorexia is?
It could be either or, whether you're making a choice or like you're just not hungry. But that's what anorexia is. In your everyday life, you hear, oh, somebody that's anorexic, they're very skinny. That's emaciated. It's malnourished, a malnourished individual. Somebody that's anorexic means that they're not eating. That's essentially all it means. But we don't really go and define the terms when we're talking about real world events. But in nursing, anorexia is just you're not eating. Okay. All right. Decreased libido. What's libido? Sex drive.
Your mojo.
Your mojo. That's right. Menstrual irregularities, thin hair, thick skin and dry, enlarged facial appearance. That's a big one. Okay, so like the bridge of your eyebrows gets a little bit bigger. Okay, your cheeks get a little bit bigger as well because your skin becomes dry and thick. Okay. Let's see. Low, hoarse voice, same thing. Bradycardia, hypotension. The complete opposite of hyperthermia. Hyperthyroidism. Now, those two medications that are in bold are very important. Synthroid, levothyroxine. Very common medications that are given. You guys are responsible. We'll talk about them more tomorrow, but these are very important, guys. Okay? These ones elevate or attempt to elevate the hormonal secretions of the thyroid gland. And what does symptomatic treatment mean? Yeah, you just treat the symptoms. If somebody's cold, you make them warm. If they're anorexic, you give them some type of medication that stimulates the appetite. What kind of medication stimulates appetite? Marijuana, something called Marinol. That's right. It's a synthetic version of cannabis. Any questions, guys? Hyper and hypothyroidism? No? Okay. This is simple goiter. This is simple goiter. That's an exaggerated version. Okay. Simple goiter meaning it has nothing to do with the secretion of the hormones. It has something to do with the thyroid gland not getting iodine. And when it doesn't have iodine, it starts acting funny, and that's what ends up happening. Mind you, that's a very exaggerated. That's probably not even goiter. That's probably something else. But it's a good picture, so I put it up there. And goiter is just a mass, folks, that comes out from this particular area, the thyroid gland. Enlarged thyroid due to low iodine levels. You guys have to know that. Anything that's in bold, folks, it's really important for you guys to know. So the thyroid gland, what do you need for the thyroid gland to?
Iodine.
Yeah, iodine. If you don't get it, okay. Enlargement is caused by the accumulation of colloid in the thyroid follicle. Colloid is a type of tissue, okay, and it just keeps building upon itself, and it gets bigger and bigger. Usually caused by insufficient diet intake of iodine. What are some elements that have iodine in it?
Fish.
Shellfish, okay, kale, that's right, eggs. The book talks about, gives you like a big list of food items that have iodine in it. Make sure you guys know them. Okay, this is what it usually looks like. Okay, simple goiter. And
Her eyes are.
yeah.
She has hyper.
Hyperthyroid.
So her eyes.
Oh yeah, the eyes.
She's got big eyes.
And she swallowed something, I think. Those are most likely tumors, folks, but it was a good picture, so I had to put it up. All right, simple goiter, folks. Enlargement of the thyroid gland. Patients, if it's enlarged, same thing with hyperthyroidism. If it's enlarged, the patient's going to have an inability to swallow effectively, so dysphagia, hoarseness, dyspnea. Dyspnea is really important. Oh, real quick, guys, don't look at this right now. Remember I talked about hypocalcemia? Okay, muscle weakness, right, or spasming. What do you think, what muscle is the most important one that you're going to be watching out for that's not going to be spazzing out? The cardiac, what else? Something with the airway. The larynx, okay? We have a lot of muscles here that allow the respiration process to occur. So if you have tetany or hypocalcemia, what's the worst thing that could happen? A laryngeal spasm. If it starts spazzing out, it's going to close your airway, you're not going to be able to breathe. Does that make sense? Okay, so make sure you guys write that down. Make sure you guys know that. All right, you give these patients, you give them potassium iodine, diet high in iodine, surgery, thyroidectomy if need be. Oh yeah, certain breads like whole grain or sourdough, they're high in iodine as well. And that's the illustration in your book, simple goiter. So Lisa and Cecilia, do you guys have a question?
Yeah, I was just thinking of my test next.
I'll let you guys know. I'll let you know. It's going to be all of the disorders, but not diabetes. Not diabetes. That's not going to be till the third exam. Okay? All right. Let's talk about cancer of the thyroid, and I'll let you guys go on a break. So what do you think happens with cancer of the thyroid gland?
The thyroid has cancer.
Thyroid has cancer. That's right. Malignancy of the thyroid tissue. It's very rare. You're going to have a small rounded nodule that's fixed, meaning it's not movable. It's painless. Okay, of course, total thyroidectomy, thyroid hormone replacement is going to be needed. And if metastasis is present, radical neck dissection, radiation chemotherapy, and radioactive iodine. But that radical neck dissection, I have a cool picture for you guys. Well, before the picture, I'll show you guys this. So, you guys remember the Mother Teresa lookalike? That had all the gross. I hope I don't offend any of you guys. She look like Mother Teresa. That's probably thyroid cancer as well. But this one as
Why
well.
is it moving all the way down?
It's not moving. It's the growths that are actually just there. So the tissue that's hyperplasia or hyperplasia, excuse me, or the growth of different tissues of the thyroid gland, it's just getting bigger and bigger. Radical neck dissection. That's just a cool picture again. Okay. A radical neck dissection. When I say a radical neck dissection, they're removing the thyroid gland and all of the what? The thyroid and what else? Okay, yeah, the parathyroid gland is being removed as well. But what else is going to be removed? The lymph nodes. Okay, when you hear total or radical, folks, it's and any other adjacent tissue or nearby tissue that's also affected. That's what radical neck dissection is.
So is his head that way?
His head is that way.
Oh.
Oh no, hold on.
Because his ears over there, I'm trying to figure
Yeah,
out.
his head is that way.
Okay.
He's facing that way. Excuse me? It's huge. Alright. Let's talk about functions of. Actually, go to break, guys. Come back and ready, guys. But look, this is essentially what calcium does, and you need to know this for the parathyroid function. We know that the thyroid gland has T3, T4, and calcitonin. What does calcitonin do? Okay, it decreases the serum calcium levels to a normal level, of course, by stimulating the osteoblast. Okay, the osteoblast, to build the bone, you need to take. I'm an osteoblast, so I need to get calcium from the bloodstream so I can put it in the bone. So that's how the calcium goes down, right? But the parathyroid gland regulates in the elevation of calcium by having the bones break down, catabolism. You guys know what I mean by that? The osteoclast, the bone cells that are responsible for breaking down the bone right before they get rebuilt. That's how the parathyroid gland functions. It stimulates that particular part of the bone. So it makes it break it down so it can raise the blood calcium levels. Does that make sense? Okay, I talked about calcium having to have a role with the neurotransmission, the neurons, muscle excitability, okay, muscle contraction, blood coagulation, all right, let me see, and of course tooth development and uterus and infancy, all that good stuff. But that's essentially what it is. It says 98% of total calcium body is in bones and in teeth. It's about that. Okay, like I said, I'm going to give you guys a sheet with this. Let's talk about hyperparathyroidism. I'm only going to talk about I don't know. We'll see how far we get. All right, so this is an overactivity of the parathyroid gland with increased production of parathyroid hormone. Hypertrophy of one or more of the parathyroid glands. Excessive growth, that's what hypertrophy means, guys. Excessive growth. So if it's getting bigger, it's going to produce more. So what's going to happen to the calcium levels? It's going to go up. All right. So it says right there, hyperparathyroidism, increased blood calcium levels. Now, I want you guys to really see this. The parathyroid, not like me, but I'm saying like, try to understand what that means. If you have hyperparathyroidism, and the thyroid gland is responsible for elevating calcium levels, of course the calcium is going to be really high, because that's what it's responsible for. The nodes in the back, the hyperparathyroid glands are going to be enlarged. So, is there going to be tetany for this one? No tetany, because hypocalcemia causes tetany. You guys remember that, right? All right. It says in fullness, which is a giant cell tumor, skull decalcification. But do you guys see why there's decalcification of the bone? Why? Because it's actually releasing it into the bloodstream. That's the whole role of the parathyroid gland. Okay, it releases calcium into the bloodstream. You'll develop peptic ulcers for the same way, the same reason the calcium, folks, actually irritates the GI tract. Look at this one. Kidney stones. Why would you develop kidney stones? Yeah, the calcium in the blood, it gets really thick, it's really heavy, it's in high abundance, so the body can't actually excrete it adequately, so you develop stones. Okay? That's important for you guys to know. You develop kidney stones when you have hypercalcemia with hyperparathyroidism. kidney stone, renal calculi. Eventually, the patient may go undergo may go through renal failure. Okay. Here's another little illustration. This is what I was referring to. We have the parathyroid glands. Okay, this is hyperplasia, excessive growth, so it's releasing too much of its parathyroid hormone. Okay, it says, let's see, the patient's going to have high blood pressure as well. Okay, let me see, what else does it say? Pancreatic stomach ulcers, you don't need to know that. But depression and psychosis is common. Depression and psychosis is common. Now, what did I say that calcium has? What role does the calcium play in your neurologic function? Transmissions, right? So if you have too much of it, there's too much going on. The patient ends up becoming depressed, and they get psychosis. What's psychosis? Crazy, cray. Yeah, the patient goes crazy. The patient starts hearing things. Their rationale isn't functioning adequately anymore. Okay, so that's why they get depression and psychosis. The patient will develop hypercalcemia, skeletal pain. Why? Not enough calcium in the bones. Because I want you guys to really know that, guys, because on the test, it's going to ask you, well, for me it seems fairly simple, but it's kind of complex because it'll say a patient has hyperthyroidism. What does it have? Hypocalcemia, all kalemia. I really want you guys to understand that there's skeletal pain because the calcium isn't in the bones anymore, it's in the blood.
So not enough.
Pardon me?
Not enough.
In the bone.
Yeah.
But where is it excessive? In
The blood.
the blood. Okay, good. Pain on weight bearing, pathological fractures. What does that mean? Fractures for essentially no reason. Kidney stones, fatigue, drowsiness, nausea, and anorexia. Okay, these are all elements that are found in hyperparathyroidism. Now, remember I talked about the calcium upsets the stomach and you may have some ulcers. That's why you're anorexic. The patient doesn't want to eat. They don't feel well because the exchange of chemicals inside the stomach is out of whack, so they're not hungry. Okay? And that's why they're also nauseous. Does all that make sense? Sort of? If the tumor is responsible, you remove the tumor for medical management or removal of one or more of the parathyroid glands. Essentially, if one of them is hypertrophied, excessive growth, you remove that particular one. And that usually takes care of it.
Will the other one like make up the difference for the one that was?
That is correct. Yeah, that is correct. The other ones make up for the one that was lost or taken away. All right, now hypoparathyroidism. Okay, so if hyperparathyroidism was excessive calcium, what's this one?
Low calcium.
Low calcium. What happens when you have low calcium? Tetanus. Okay, what two tests can we perform? Chavostex and Trousseau's. Yeah, that one. Sounds like trousers. Okay, it's trousers. Decreased parathyroid hormone, decreased serum calcium levels, inadvertent removal or destruction of one or more of the parathyroid glands during a thyroidectomy. This is so important. This is what I was talking about when we were talking about hyperthyroidism. Okay, hyperthyroidism, the excessive growth, production of hormone by the thyroid gland. If you have a thyroidectomy, you may cut it or destroy it, and that's when the actual thyroid, the parathyroid gland, doesn't secrete as much of the parathyroid hormone that it's supposed to. So anytime a patient has is it really hot back there?
Yes.
So anytime a patient has a thyroidectomy, what do they run the risk of? Being nicked, which leads to what? Hyper or hypoparathyroidism? Hypoparathyroidism. So all this hyper, it's really confusing, guys, and that's why I try to keep repeating it and I confuse myself sometimes. But it's important that you guys understand that, folks. That last bullet point is so important because it's going to come up on the exam. It's one of the most common reasons as to why a patient's calcium level drops due to the glands. Okay?
Are they connected or they're just really close to each
No,
other?
they're connected. That was a poor illustration, the one that showed them on the sides.
Mm-hmm.
It's actually right behind it, right on the posterior ends. So we talk about, this is my thyroid gland, right?
Mm-hmm.
So they're like right there, right there, right there, and right there.
So when you remove the thyroid, they are
They're connected.
Okay,
Yeah,
that's
yeah,
why
they're
you can make
connected.
it.
The blood supply, it all comes from the thyroid
That's why
gland.
you can make it.
So let's say you don't actually hit the parathyroid gland, you might cut off one of its capillaries, you might cut off one of the nerve endings that actually stimulate it to secrete. All those different elements are included. Yes?
How come if you remove one, it doesn't cause all of them?
Because they're removing it, when they do an actual thyroidectomy, they're removing only the vessels that affect that particular one. So that's why it's a lot more adequate that way. Does that make sense? All right, so neuromuscular hyperexcitability. All that means, guys, is tetany. Hyperexcitability doesn't mean that you're like flexing and looking all cool. It means that you're doing this. So the patient very commonly is described as having like a Parkinson's-like shuffle or a gait, or the little hand tremors. That's what hyperexcitability means. When you do the Schwastex, you just do. I mean, do this to yourself right now. Does anything happen? No, hopefully not. Okay, because your muscles are all in that homeostatic frame. However, if you're hypocalcemic, they're hyperexcitable. So if you start messing with them, they're going to start jerking around and messing up. Does that make sense? That's hyperexcitability. Involuntary or uncontrollable muscle spasms. The trousers. Okay. Tetany, laryngeal spasm. Very important, folks. Very dangerous for the patient because if the larynx starts spazzing out, what's going to close up? The airway. What's happening to the patient?
Died.
They're gonna die. Yeah, the airway. So what do you want to? So what do you want to have at the bedside? Yeah, tracheotomy trach. You also want to have suctioning, of course. But what's more important? What's of paramount importance? Tracheotomy, because it supports the artificial airway. And then stridor, cyanosis, if the airway is actually being affected. Parkinson's-like syndrome, meaning shuffling. Okay, the tremors of the hands. When we get to neuro in fourth term, if it's with me, with Parkinson's disease, yes. Stridor is a respiratory, a breath sound. It sounds very much like a mixture of wheezing and crackles. Okay. Okay. But essentially, that's what it is. They don't really even use stridor anymore to describe it, but it's an abnormal breath sound of the constriction of the airway and of some fluids building up. So that's what stridor is. And you guys know Schwastex and trouser sign, right? Okay. Tomorrow there's a quiz on all this stuff, by the way. Oh yeah. All the time, guys. All the time. All right. So here's I didn't give you guys a quiz last week because I only had you guys Tuesday, but today, positive Schwastex if they start doing this. Okay? And this is the trousers. They throw up a gang sign or what?
Yeah.
That's actually the K in silent. But do you guys see how that happens though? Because it spazzes, it's not controllable, so it's like whatever it's doing. Now, calcium glutamate, very important. Calcium glutamate is the synthetic form of calcium that we give a patient that has hypocalcemia. Okay, we give them this, and it actually brings up the calcium level. This is a form of calcium that bonds to the sugars that actually is received by the blood cells because of its sugar component, and essentially is absorbed. That's all it's talking about. Calcium glutamate, that's what it is, or intravenous calcium chloride. These are all medications that we give to increase the calcium levels. Know the average calcium levels, folks. What does the book say? It is 9.1 to 10 point what?
5.
To 10.5. Know the therapeutic value, folks. Now, if I tell you the patient comes in and you draw a serum lab test and the calcium level is 7.6, what's this patient going to be at risk for? Tetany. Hypo. The patient's hypocalcemia. So they're going to be at risk for tetany. What test do we perform? Schwastex and trouser sign. Okay, the test. That's what actually is indicative of decreased calcium levels. And why do we give vitamin D?
Because calcium works better.
It absorbs it.
Because calcium, vitamin D, folks, helps it absorb. Without vitamin D, you can't have the calcium being absorbed.
So for the calcium glutamate, you said the glucose helps the cells absorb the calcium?
Mhm.
Okay.
like, I'll give you an example, like that calcium chloride, okay? The chloride helps the pH, like when it goes inside your body, it's homeostatic. It's isotonic, meaning it's just how your body is. So it's not only calcium chloride, but it's potassium chloride or sodium chloride. It's got that chloride because it maintains the tonicity or like the pH of the body, the balance. So that's why it goes in, like if it's part of your own, your body won't reject it and it'll just move into your body without, at ease. Does that make sense? Okay. And all right, we'll talk about adrenal.
No.
Okay, we'll stop here, guys. I'm not going home yet. Let me go make.